Good evening, good afternoon, good morning, because you could be watching this anytime, but if you're watching it live, good afternoon if you're in the UK, and we know we get some people from around the world watching this, our continued series of webinars for the healthcare professionals. Today, I'm delighted to be joined by a stellar panel of experts who are both insightful and erudite, and we're going to have a great webinar. And we want you who are viewing, particularly if you're live, to get involved. There's a panel on your screen. You can put in some questions and we can try and put those to the panel in the tight space of the 1 hour that we've got. Today, I've just got to mention, is thanks to the good people at the Demand and Capacity Optimisation tool who sponsored this, and that's why we were able to do this. But today's big question, the big question that my fantastic panel are going to try and answer is preempting patient demand in general practice. Why don't we? And how can we? And by the way, I'll caveat that we know some people do, but why don't we all? What I'm going to do, I'm going to ask my panel to introduce themselves, and I'm going to ask them one question just at the start. So I'm going to get 90 seconds because we're tight, and I'd like them just to answer the question during introducing themselves. I'm going to go first on my wonderful panel to Bilal Patel, who's a GP. Bilal, introduce yourself, but tell me, DCOT report, it emphasised that high-quality, patient-centred care. And how does preempting that patient demand align with that vision? Bilal.
So, hi everyone. I'm Bilal Patel. I'm a GP at Solihull Healthcare Partnership. We are a large-scale provider in the Midlands. The DCOT report, I think patient-centred care is something that we all aspire to, and it's getting that balance right of trying to make sure we can optimize all of the services that we've got around the patient, the admin, the bureaucracy that is that machine of general practice that's out there, and really target it to those people who need it. And that's something that we're all striving to achieve.
Great, thank you for that, Bilal. That's great and perfectly on time as well. I like you. Next on my panel, if you'd introduce yourself, Nick Downham, Independent Health and Social Care Improvement Specialist. Same question to you. That patient-centred care, how does preempting that patient demand align with that?
Well, I think patient-centred care just moves into a definition of broader quality. So if you take, for example, the Institute of Medicine's fabled definition of quality, you've got timeliness, effectiveness, good experience, cost effectiveness, safety. And I believe they're not mutually exclusive. We don't have to choose between the two. But to achieve them all, we can't just maintain a position of reacting to illness or reacting to what walks through our door. We have to be much more preemptive and anticipatory and planned in order to achieve those things. Thanks, Nick.
And you've got another 30 seconds because you didn't introduce yourself and tell us what you know about this and why.
What do I know about this? Sorry, I was just building on your introduction there, Darren. So I specialise in helping primary care organisations with their improvement journeys. So I believe passionately in the role amazing public services play in helping people live healthy lives. And I do that by helping primary and secondary care organisations, both directly and also in my teaching on clinical leadership programmes.
Thanks, Nick. Liz, you're going to perfectly answer the exam question. You're going to introduce yourself, and again, you're going to just touch on this, why that preempting patient demand aligns with the vision of patient-centred care.
Yeah, thanks for that. Yeah, my name's Liz. I work in a primary care network, a large primary care network, as a digital and transformation lead. So yeah, preempting care and the DCOT report around quality. I think my take on that is that we really need to think about some of the areas that DCOT pulled out of that report around comorbidities, long-term conditions, the increase in mental health, the increase in patients that we've got they're asking for testing around, screening around autism and ADHD. And if we're thinking about personalised centred care and how we can manage that demand in general practice, we have to think about them patients, and we have to think what is important for them patients when it comes to patient-centred care.
Thank you, Liz. And last, afternoon, please. Sajid Khan, same question as you, and please introduce yourself.
Hi, everybody. My name is Sajid Khan, and I work for Develop Consulting, and we are one of the 4 delivery partners that are supporting NHS England in delivering and rolling out the General Practice Improvement Programme. I've kind of been working in primary care for the last kind of 10, 15 years. And over that time, we've worked with loads of practices, to maybe 1,500 to 2,000 practices on a national scale. And so we have, and I manage that program and have people in practices on a day-to-day basis. So we have a really good idea of what is going on, what practices and challenges the practices are facing, and how we can implement some of the concepts, theories, and ideas and models of care with practices in real life. And I guess my take on the question around, the Darcy report and how preemptive demand is important is that I feel that through that process, we can move from more of a reactive model to more of a proactive model. And what I mean by that is, if we can anticipate patient needs, then that means healthcare providers can offer more timely interventions, which means reducing the likelihood of conditions worsening, right? Because we want to improve patient care. And again, ultimately, what this means is that proactive approach ensures that patients receive the care when they need it, rather than always reacting to these emergencies.
Thanks, Saj. And I think you've touched on something really interesting there, because, and all of you have, not only does this help the patients, but it helps the healthcare professionals we're talking to today to get a grip and get something of their life back, which is quite nice. To really push a bit more on this, there's a whole debate about how much control the GP practices have over that demand. But the first thing you've got to do to have control over anything, surely, is to measure it and monitor it. Because if you don't understand what you've got, you can't do anything about it. Nick, I'm just going to come first to you from your experience of working across multiple practices. How do the GP practices currently manage and monitor that patient demand? And what are really the limitations on those approaches?
Well, I think the first thing to say is GP practices are not particularly homogeneous. So, they differ in this. You have awesome practices doing lots of anticipatory stuff and lots of operational management, pulling in data sets, especially at the level of PCN as well, beginning to make sense of this kind of murky world. On the other hand, you've got some practices barely getting through the day job, reacting, just reacting to today's work today, just getting through, and effectively trying to put sticking plasters over more, I suppose, systemic problems. And lots in the middle doing awesome work as well. So I think, lots of people doing good work, lots of people struggling. Your point about data, I think data is the first sort of building block of allowing reflection. Okay, how are we doing? How are we not doing? You can get so far with sort of subjective reflection, i.e. my opinion of what happened. But actually, if you use data, that's a much more objective, or should be a much more objective data source, which combined with our experiences get us a lot further. Okay. In terms of the notion of control, I think it's probably important to differentiate between control and predictability, and I suppose evenness or unevenness of the work as well. They're 3 really important things. So while the notion of control might be a little bit too far away, although we do make our own work, and perhaps we can get on with that in a little bit, the notion of predictability and unevenness is really important. So it's unevenness or unpredictability, both in terms of volume of work, in terms of the acuity and complexity of the work, and also the capability of different staff and staff groups. It's that unevenness that is really damaging. So if you're trying to run a practice, especially as they get a bit larger, unevenness makes things really hard to plan for. Okay. It's almost better to have constantly high demand than really, really uneven demand, because at least you know how big your problem is. But our demand changes in terms of case mix, changes in terms of volume, and also our capability to do work varies wildly as well. So unevenness is probably a big thing, as well as control or perhaps even timings and patterns.
I'm going to come to Liz next on this, because you do that whole transformation piece and also a bit of a focus on digital. Are you seeing different things in different practices? Are you seeing some best practice, and are you seeing some zero practice?
Yeah, I think Nick said a very poignant point around the variation in practices. Some achieving really well, and some are not achieving too well, or not even knowing, which is more frightening. Not even knowing if they're achieving or not. But yeah, from a PCN perspective, working in a large PCN with 12 practices, the variation within PCNs with the same sort of population and the same demographics of patients can be very different as well, because you have different profiles, don't you? Bigger practices, smaller practices. I think when it comes to data, and predominantly a lot of my work is around that sort of health population management data, pulling data sets in for specific populations within practices. I think it's all about context and putting that data into context. And we really need to move to a system where we're collecting data and measures that matter to patients, but also matter to the practice as well. And that's where the context comes in. We do a lot of data collection in general practice. We collect lots around wait times, we collect lots around demand, what activity we're delivering, what capacity we've got to deliver that. But we miss some of the nuances as well around that data, which is that content. We miss why things go wrong. We miss that patient sort of level data around who are coming in frequently, who are not engaging, who are not coming in at all. And if they're not coming in, why are they not coming in? Which is all down to that sort of health population management. And we're very good, aren't we, at saying that, and the DASI report even said this, isn't it? We're delivering more appointments and we have been delivering more appointments in the last few years. But are we delivering them appointments because we're pushing patients on to more appointments? And do we understand if we're doing that? Yeah, we're seeing more patients. We're seeing more patients online. We're seeing more patients through telephone. Some need to catch up. We're seeing more patients face-to-face as well, post-COVID. But we are delivering, but are we pushing patients further along the line?
Are we as effective as we used to be?
Exactly. And that is a really, really key point that we have to dig deeper into.
Great. Thanks for that. Saj, you've worked with hundreds, if not thousands now, of practices with a GP improvement program. So you must have seen lots of different approaches to monitoring that patient demand. And that question mark about managing it, can we actually manage it? What are you seeing in terms of variation and across the approaches? And what's the real limitation on that?
Thanks, Darren. So yeah, we've seen, that first point there around variation. Data analysis is easy, right? It's the idea, the concept seems really logical about being able to gather data, understand some demand patterns, and then from that, we're able to, manage our capacity and get that sorted. So the concept is really quite simple and easy. But first of all, I think, Nick touched on the point, getting data is far harder than it should be, or feels a lot harder than it needs to be, right? Well, that's the first point. Second point, we've got huge variation in not only the practices, their capability or the capability of individuals to extract data from the systems and knowing the systems well enough to be able to pull that data, but then also having the skill sets to be able to analyze that data in an effective, meaningful way, to be able to visualize it, to be able to draw conclusions from it, and then to be able to act upon that. That in itself is sometimes a challenge due to capacity, skill set, knowledge, experience, all of those different things. On top of that, then, you've also got variation in systems and the data and the type of reports that they provide and how easy it is to be able to get that data from those reports in a meaningful way. And what we found was, having worked with so many practices, that sometimes when we extract data or pull data from their current systems and analyze that and present that in a way to practice staff and clinicians, sometimes they challenge that data themselves and they feel that data isn't accurate, honest, or reflects what actually goes on in the practice. And so sometimes what we have to do then is to really break that information down to understand, why is that? What is it that we're not capturing? What is it we're capturing in the wrong or unmeaningful way that allows us to be able to understand what goes on? And I feel we do that in ways where we try to break that down across some key concept areas. So the first one is, how do the practice deal with patients' first interaction? So what do we do? What do we capture? What do we record? What do we send away? 2 is information around signposting. So where do we, how do we, to who, to when, internally, externally, etc., etc. The consultation itself. So how are we managing the consultation, pre-consultation information? And like Nick said, how effective are we in that consultation? And actually, is that consultation long enough to be able to do what we want to do within that? And then last but not least, what are the follow-up or after consultation actions? So like Liz said, are we bringing people in more often than we need to be or not? So there's a whole huge number of things about how not only do we manage the data, but how do we monitor it? And then as a result, what do we do with that going forward?
Bilal, I'm going to come to you, the pointy end of it, a GP. How do you feel, or what are you doing to manage that demand, and particularly that monitoring of demand, that the data becomes useful data rather than just noise?
Yeah, I think just taking it back a step, there's 2 parts to demand, as we've said, sort of your demographics. So analyzing your list size, so you can look at your patient population and try to preemptively figure out what your demand is going to be. And then there's the day-to-day side of demand, which is what Saj touched upon, and how that demand materializes once the patient's in the room. Because quite often you might have patients coming in for a particular chronic disease clinic, might be seeing the right clinician for that particular problem, be it a hypertension clinic or a sexual health clinic, and they're in the room, they've worked hard, they've fought through the system, they've managed to beat that 8 a.m. rush, or use online consults, or try to get through and they've got that Willy Wonka ticket to get a GP appointment. And once they're there, they think, right, now I'm in front of a clinician, I can deal with all of my problems. And that's where failure demand then comes into it, because actually that clinician is only there to help with their hypertension and can't really deal with their orthopedic problem, or can't really deal with their other issues. And that is hard to quantify. It's really difficult to have any tool that will predict that, because patients in themselves are unpredictable, and you don't really know what's happening in their individual lives. But the macro side of things you can really predict. And I think if we can focus on the macro side, then the micro will generally be something that is the froth on top of the big wave. I think where practices struggle is sometimes they get too caught up in that froth on top of the wave, but miss the fact that they're drowning in the complexity of modern general practice, and not able to understand their demographics and to use their manpower and their workforce across, whether it's their practice, their PCN, their locality, to have the right type of care for the right type of patients. You know, that triangle of care, 80% of patients will only need a little bit of, maybe one appointment, or maybe even remote access, where they're engaging with you through e-consultation tools. Others may need a face-to-face appointment, and that top sort of 5 to 10% may need complex specialist care within our surgery, or with the help of secondary care. So if you can try to preempt that side, then you can make sure that, again, those with lots and lots of complex problems are encouraged to come to see a generalist, rather than going and seeing a specialist diabetes care nurse who may be fantastic to deal with that patient's diabetes, but then can't really help them. And then you're creating 2 appointments or 3 appointments, and then workload through the front door, and that circular care. And as we've got more and more diverse with our practice clinical I was going to say staff or workforce, it's meant that things are much more fragmented. But they were equally the case in the past. Sometimes patients would come and see a colleague who didn't really understand mental health as much as some of the others in the practice. So some patients in a small practice would know who's the person to go to for a particular type of condition, or the receptionist would say, oh, actually, you're better off seeing so and so. But in modern general practice, it's so complicated, and the larger the practices are, that level of continuity is sometimes helpful, but actually you need to see somebody who's right for you rather than who you feel would be the best person to see you, because you've got a longer term relationship with them. So yeah, I think when practices are looking at their own data, they need to first identify where they're struggling. And if they are struggling more on the macro side of things, then put your efforts into that. If it's more the day-to-day demand management and trying to facilitate that, then that's where a lot of the digital tools and the stuff that Saj pointed out will help really manage your and help you gather that data in a more structured way, because I think that's where a lot of practices find individual clinicians will document things in a different way. Some will make lots of notes, some will use quick keys, some will actually code as they're going along, and that makes it much harder for the administrative staff to then understand what actually took place in that consulting room. And if you ask GPs or clinicians to fill out forms as they go, the first few will get filled out very well, but as the day goes on, they'll get very sparse. So sorry, really long answer, but hopefully it gives you a lot of perspective.
No, it does, and you've really touched on something that's hugely important. I think, Liz, you're a great proponent of it. Only if we measure something can we do something about it. Do you actually feel we're measuring this, or even understand the measurement?
Yeah, I do think we measure it. Do we action plan? Do we do something about it? That's the question, isn't it? Do we learn? Do we learn from what we're measuring? I'm not sure that we always do. But I think that's a bit of my mantra. If we measure it, we can do something about it. And something about it might not be we need to not do anything at all. I think for me, I keep saying about context. When I was reading the DASA report, there was a comment on there around wait time to see a GP has gone up. And I'm like, well, isn't that the work that we have been doing? That is the work that we're doing. We're trying to care navigate. We're trying to signpost. We're trying to make sure that the right person sees that patient. And it's the right contact at the right time. So, it could be positive that wait times have gone up to see a GP.
And who's setting that expectation, Liz?
Exactly.
Right? So if all you offer is same day appointments, everybody expects a same day appointment.
Exactly.
But perhaps if we could reliably offer an appointment in a week, and it will be reliable, you'll always get one in a week if you want it. Maybe people are okay with that. But the expectation is same day or tomorrow, isn't it?
Yeah, and that change around access and the amount of work that we're putting into access really is diminishing the work that we need to do around pre-planned care and the quality of that pre-planned care. And we're on a vicious circle at the moment. We're doing so much around access, making access important. And of course it is, because that's a patient's voice and that's what they're saying to us. But if we don't break that cycle and do something more about that preempted care and that planned care, everything's going to end up needing to be seen same day, because we're making as patients be less proactive and more reactive. And we all know on this call today and on this panel that proactive care is very, very important.
Thanks, Liz. And Nick, I know you're sort of you love your data. You love your data, but is too much of the data we collect basically a history book of what we did and not what we should have did?
Yeah. So I mean, if you put yourself in the position of someone running a practice, or a senior GP or a senior AHP or practice manager or network manager or whatever, you're faced with a load of imperfect data sources, completely imperfect data sources. So they're sort of promising, but they're never as easy as they should be. There's always problems with them. And you might have 10 or 11 different sources of data from your practice system, from your appointment records, your prescribing trends, your referring trends, your next steps decision making, right through to, there must be another 5 or 6, I can't think of them off the top of the spot, but all of them don't give you the whole part of the picture when you're trying to answer this picture. You might be getting population health data packs, which gets emailed to you every now and again, or you might even be given a dashboard if you can remember to log in. All kinds of stuff that might help you a little bit with this picture. But as a senior member of staff, the problem is making sense of that in the moment and at different levels. So what does it mean to me as a year? What does it mean to me this month? What does it mean to me perhaps today or in the week? How do I make sense of this? What's my operational decision making? Has anything changed? Okay. And going back to sort of Liz's point about the measures are important. You get what you measure. That's a blessing and a curse. Okay. Because as Liz was alluding to there, if all you measure is a reactive system, like if the only game in town is access, then you're going to get access. And the compromise will be effectiveness. So a measure, there's a guy called John Seddon who's really good in this stuff. His saying is a measure becomes purpose. So we've got to be careful what we wish for with this. So we've got to be very, very careful and balanced, right? And that gives you full circle about how to make the most of this imperfect picture. It depends on where you want to go, right? So if you're a practice or a group of practices and your mission, your purpose is to react to illness, that's what we are. We are a reacting to illness machine. Okay, whoever turns up, we're going to do a really good job and be safe with them and be effective with them. You'll set up and you'll require different data to do that. Okay, if your mission is to promote the well-being of my community and support them to live a healthy life, okay, you will set up in a different way and you'll need different data in order to do that. So really it comes down to purpose. What is my role here as a general practice or a PCN in my community? Okay, half of that purpose comes from, we get quite a lot imposed on us from contract, but there's quite a lot of wiggle room here in terms of where we want to go, because that dictates your pictures of what data you need and the kind of questions you might ask of it.
Thanks, Nick. Saj, I'm just going to come to you. I'm just going to put on a question of what are the sort of key drivers and spikes in primary care, and can we anticipate them? I've had we've got Hamish in the comments just saying, look, actually demand's entirely predictable, and we've got another great comment. Keep the comments coming in from Sarah, just saying that we tend to focus on the unusual rather than the day-to-day, and we all know Pareto, 80% of it's going to be the same old stuff. So is that demand predictable, and are there spikes from external forces that we claim are external that actually we can predict anyway?
Thanks, Darren. Yeah, so from my experience, it's quite interesting because in some of the practices, and not all cases, but practice managers and clinicians sometimes feel that demand is unpredictable and are not convinced of the level of control that they have on demand as a practice. So more of them don't realize they have more control of demand than they do. And what I mean by that is, at the moment, we run a very reactive model. Like Nick was saying, if everybody's expecting an appointment today and we give it to them, fine. And with those that we don't, then what happens to them? But actually, we also have not only urgent, but we have routine appointments as well. And it's about understanding what can we do with some of those. And like Nick said, sometimes due to some of those concepts that we have in place, like working with one of the practices that we supported, they had massive ATM rush, right? So it was about improving access. So let's get everybody to answer the phone calls in a timely manner so that people are not waiting an hour or 45 minutes to get through and get there. I like that concept, Willy Wonka ticket. And so what instead happened is they put a lot of people on to be able to answer patient queries and support and take those phone calls. So the number of calls answered went up, which was a brilliant result. But what happened was a lot of those calls, because of lack of skills, knowledge, and experience, they weren't able to resolve those patient queries. And as a result, ended up bringing those same patients back again the day after for them to be able to answer by somebody else, or wait to get an answer and then to bring that, then to go back to that patient or bring that patient call back in for us to provide them with an answer. So all of a sudden we start creating, because we're trying to solve one problem out here, but not doing it effectively, we cause another problem, i.e. failure demand on this side, by all this extra demand that we're bringing on ourselves over and on top of what was expected for that day and for the next day. So I think there's understanding demand and doing something about it. There's huge challenges around that. So specifically around what we want to do is, I guess, 4 kind of key things really. One is reduce demand. So how can we educate patients? How can we pre-plan some of this? And this comes into the next question that you just alluded to earlier on, Darren, which was around how do we anticipate that? So, looking at seasonal trends, looking at winter pressures, looking at aging populations of chronic diseases, putting on mass clinics, etc. All these, with the new government, new policy changes, there'll be something else coming through. Understanding what do we do about those and how do we plan and manage all those things will be coming into it as well. But so how do we reduce demand, and then how do we smooth that demand? And Nick touched on it right at the beginning about if you have this huge variability and peaks and troughs, this can make it more difficult to manage some of that going forward.
Thanks, Sajid. Bilal, do you sometimes you're driving into work and hear something on the radio and think, oh, there we go, this is going to be a busy one? I mean, do you feel like you're just a small yacht being blown around in the winds?
There's always that. I mean, you do, whether you listen to Radio 4, Radio 5 Live, or you pick up the metro on the tube or the bus on the way into work. You sometimes have that dread as to which superstar has said something, or somebody's come out and told the world about their illness. And sorry, I've disappeared into darkness, haven't I? Sorry. And that is something that will cause an unexpected spike. So suddenly you'll have a rush through the door of people wanting to get their moles checked because somebody has been diagnosed with a very rare, awful skin cancer, or whether it's prostate cancer, whether it's cervical, or the menopausal HRT rush that we've had, and in some ways, I love when that happens, because it helps to raise awareness in the community, and it shows that those people who did have that thought at the back of their mind are actually worried about these things, and it's prompted them not just push that thought away and carry on with the rest of their life, but actually think, yeah, actually, maybe I should get that checked. And then they come and get in contact with the surgery, and we want them to get in contact with the surgery. Well, it's up to us to be able to say, yes, absolutely, we will deal with that, but it may not be as desperately urgent for you to see somebody today, but here is an option, and we will give you an appointment. And whilst you're there, we will check your height, your weight, your blood pressure, your smoking, your alcohol. We'll do some preventative care. We'll look at you holistically, and maybe you're on some medication. We'll do your medication check whilst you're in the room. So that's an opportunity to get some of these patients in to the surgery, and they may be there for one thing, but actually deal with other things. And I mean, we touched on the length of an appointment and the effectiveness of an appointment. It's that constant making every contact count, and how do we make sure that is a 10-minute appointment really appropriate? Should we be going for longer appointment times and actually spending that time with every patient and saying, okay, well, today's appointment is just a quick 10-minute appointment, but I want you to come back and see us, and next time we'll have a 20-minute appointment, and we'll go through lots of other things with you. So I dread it, but I thrive on it. I mean, it's you do like that, and COVID was a real test of how the NHS worked and how the NHS sort of pulled together, and from those sort of inceptions of fleeting thoughts up and down the country to people really taking those, running with those, and making changes on the ground to set up pop-up clinics and integrated ways of working. Those red zones, those safe zones, maternity and infant vaccination zones. Those are great examples of how, if we are faced with a challenge, then we can respond to that. So yes, some of it is you do need to be dynamic. You need to be supported by great admin and management staff. But as Liz pointed out, we need to learn from that. You can't just do the process. You need to document it as you're going along, keep minutes of all the meetings, but then actually have that post-action review where you can delve into some of the meat of it and think, actually, maybe we could have done that a little bit better, and next time around we'll put this into our disaster recovery plan that's sitting dusty on the shelf somewhere.
Nick, just coming to you. So I can remember back in the day when I was vice chair of a PCT every year, getting a load of documentation saying Christmas would be fine, and I'm going, well, it won't be, will it? Because you haven't changed your staffing numbers, and I can predict Christmas. It's been going on for a while, and we don't see Tesco's and Sainsbury's suddenly having these problems. They seem to be able to predict everything from good weather through to that there's a football game. Is there something we can learn from that? And do we focus too much on the anomalies that somebody like, say, mentions they've got a condition on the radio and it changes everything for a couple of weeks? Do we focus on that and not what we can do?
I think this is probably where Hamish in the comments is talking about as well. So obviously a big difference between two big differences between a supermarket and a public service. So number one, the supermarket can choose to withdraw from a market that it doesn't that's not profitable or not worth its while. Whereas with a health service, we are there to do the work whether it fits or not. Okay, especially general practice. And I suppose the second thing is a supermarket does, because I used to work when I was a lot younger for a supermarket. One of my first jobs at Sainsbury's, they surged their staffing during the festive periods and so on, right? So when I used to come back from university, I used to earn my terms money. So that's exactly how that kind of thing works. Now we don't quite have the resourcing to surge our staffing in that way, so we have to think a little bit differently about what's going on. But we can think very carefully about a number of probably obvious things, but these do trip up practices in ways. Is so number one, the work we do is a direct result of the capacity we have, so we kind of only let in what we can do most of the time. So there lies an interesting thing in terms of making sure we're really rigorous with our staff planning over the year. Okay, because that obviously helps us with our demand management. We obviously overlay lots of different campaigns through the year. So we've got things like flu campaigns, we've got our educational campaigns, we've got things like flu education, things like long-term condition reviews. All of these things are they've been around since the dawn of time. We know we do them, and yet perhaps we might be able to look at them over the year and think, when do we not want to do some of this stuff? Could we start some stuff earlier? Could we make sure we're not doing stuff at this point in time when we know we're going to get a surge in work? Can we then think about our skill mix that helps us be a bit more flexible as we do that? So I think there's a lot of stuff going on over a year which we can move around to give us a little bit more of a chance during that year. Okay. Now, the kind of thing I was just thinking about when Bilal was talking was he's been describing this kind of change in general practice over like 15 years, which is we've gone from like a mono-professional model to a multi-professional model. Okay, with lots and lots of different flavors of staff group, all awesome. Okay, but that makes it really, really hard to join the work together. Right work, right person. It used to be really easy. Just give all the work to the GP and it was there we go. But now it's a lot harder. We've got probably 10 flavors of clinician as we do that. So the question about are we effective with our work becomes much, much, much harder to answer. Okay, so is the reason why perhaps there is a Christmas surge because we end up fitting wrong patients with wrong people and we're less effective and we have to see them again? Okay, or we're wrong patients seeing people they don't want to see. Okay, so they want to see the GP and we've asked them to see someone else, they're going to come back again. So I think there is a notion of thinking about our staff capability and our skill mix and thinking about when to signpost and when not. When do we need actually to think about, is it more cost effective to have a higher caliber of staff member because we don't have to split the work up? Or is it more, or can we rely on our processes of triage? Can we rely on our processes of signposting to split that up? So I think there's a lot of reflection when it comes to that. But I do think we are in much more control of the year than we think we have if we were to sit down and plan that year out and say we cannot be doing some extra stuff at that point of the year because we dig ourselves a hole, and we know it happens every year.
Thanks. And Liz, bear in mind these drivers and spikes, and some we know about, some we're not necessarily sure about. How can those practices really transition from that reactive into that proactive? What tools and strategies are most effective? And you did quite a lot in the digital space. Are there some digital tools that are out there that are doing this, so that actually help rather than just create more work or hindrance?
Yeah, we've just done a large piece of work around remote monitoring in our PCN, which we are evaluating at the moment. Too short to evaluate whether it's had a benefit on patient outcomes, but significantly long enough to know that that is definitely an opportunity that's missed for general practice. And fortunately, working with our staff in our PCN, then wider sort of staff that we do have now in general practice, we can use digital at a sort of hub level rather than individual level. So it's economies of scale. So, working across multiple practices, having one hub that's managing remote monitoring for a specific disease, or for, in our case, it was for comorbidities. So yeah, we do need to make that transition. We absolutely all know, don't we, if we engage with patients and support patients to self-manage, it will have a positive effect on them, and they're less likely to be them sort of heart sink patients, or they're frequent attenders, or become reliant on us in general practice. But I, from personal experience of working on a footprint, looking after long-term conditions collectively in that population management role for 12 practices, we've got challenges because patients are really starting to want that sort of on the day answers straight away. The society is at that point, don't we? We're all got used to having fast food delivery on the day. And the patients are wanting that as well. So we have to make that shift to proactive. We have to not work in isolation. We have to work across our PCNs and multiple practices, and we definitely have to work in collaboration with third sector voluntary organisations and our partners. And from a PCN's perspective, that's my driver all of the time. It is supporting practices to do that outreach work, to do that community reach work, to do that sort of if patients can't get to us from an engagement point of view, we'll go to them. So using technology like point of care testing, rather than expecting a patient to come in and having a single appointment and have their sort of annual review, we're doing more around outreach, going out into communities and doing that work. So we do need to transition using technology, but at the same time using that concept of that proactive work.
Thanks, Liz. But Bilal, what are you seeing in terms of that movement to proactive? And again, are you using any technologies to do that, or are you just, I don't know, what are you doing?
Well, I mean, we've got some great GPs in at SHP and great managers as well, and so they're spent a lot of time looking at our population. We've got a admin staff management training in place for our care navigators, so they're looking at patient education, signposting, that kind of stuff. And so we've also got a communications officer as well. So that comms person is trying to help our clinicians and our managers to look at the demand that we've got. And when we do our push for flu, we're not having other SMSs. We're trying not to have other SMSs going out at the same time to confuse patients. But it's good to try to map out your workload over the year. Try to understand your demographics. It was very hard to look at our existing tools that we had and try to just click a button and have the information pop out at you. You've really had to almost design your own searches, and it takes brains far bigger than mine to do that, because the data it's so nebulous. And if you get your search criteria wrong, it just spits out jargon. I mean, we touched on all the different data sources that are out there that are external. And the difficult thing that we find is that they're all different time horizons. So some will give you prescribing data for the earlier part of the year. Some will give you your prevalence data and your activity data that's 2 years out of date. So, looking at 22, 23 is great, but is that, I mean, if you're an expanding practice, or let's say you're a university practice, and your population's doing this over, up and down over the course of the year, how do you extract the data? Where do you go to get the right data to manage that demand? It is hard, and I think sometimes going to external consultants is where a lot of practices will drift to when they're at scale, certainly when they've got to large scale. But I think going to a digital transformation lead as part of a PCN, sometimes you can get those economies of scale within that PCN footprint without then needing to go external. And there's a lot of shared learning that's now happening between PCNs and neighbouring PCNs. So if there's good practice that's happening, it can be shared across the locality. And I think that's somewhere where we don't have to keep reinventing the wheel.
Thanks, Bilal. Nick, I'm going to come to you. Right, we promised at the start of this webcast we'll talk practical. Give me some practical examples.
Well, perhaps building on what Bilal was saying. Yeah, Bilal, you were just discussing supporting your care navigators or reception teams. Forgive me, I don't know the exact phraseology you used. So some of the analysis we've done, and I've helped and worked with Saj on this kind of stuff, would be to have a look at the variability in decision making across front of house or reception or care navigation teams. So who's making what decisions when? How does that vary over time? Okay, because your front of house is effectively sorting and allocating, and you may even have a clinical triage step in that as well. And who you let in and who you allocate to and who you signpost to will vary by staff member, whether it's different GPs or different care navigators. And that will vary quite a considerable amount. So depending on who's working, you'll have a completely different work profile than the next day. Okay, so that variability is within your grasp. Okay, number one, we've got to surface it, okay, and begin to ask questions about it, not in a performance management way, but just it is what it is. Why perhaps might we be making different decisions? Is it about caseload? Is it multifactorial? How might we get in that? But have the conversation, because that variability has a dramatic effect on the work you're doing. Okay, you can then ask exactly the same questions of the consulting clinicians. Okay, so when we've done this kind of analysis, we've asked consulting clinicians to document their next steps nice and clearly, so we don't have to go down the rabbit hole of trying to figure this out via searches. But what are your next steps with this patient? Do you envisage the practice seeing this patient again in the near future, 2-3 weeks? Okay, and lo and behold, it can be on some practices, this is up to 50% of all of the patients are asked back with it and are expected back within 2 or 3 weeks. Okay, so that might be a formal ask back, as in I need to see you again. That's part of medicine. It might be as part of a bloods test, a diagnostic. It might be just that the GP's got a really good feeling that you're going to end up seeing this person again, regardless of what I say. Okay, but regardless, 50% of people coming back in. Now, of that 50%, you're going to see a big chunk of them again, right? So this is like compound interest on your mortgage. So a little tiny percentage difference in the number of people we invite back or expect back has a dramatic month-on-month effect on our workload. So we can predict a huge proportion of what is going to come back and who's going to come back, the type of case, the acuity, the skill mix, and make some staffing decisions based on how to respond to that. We can also, again, ask questions about, that's interesting, why does that vary over time? So why does that vary by clinical professional? That's really interesting, right? So what's going on there? Is different clinicians attract different types of cases? Is it something to do with case mix, and is it multifactorial in that way? Or is it a training issue or a confidence issue? Okay, so all of a sudden, when we map out all of these different flows and begin looking at the variability, you then to realise actually a really, really big chunk of this, especially if you look at seasonal trends, is either known to us, not a surprise, or yeah, we actually have some influence over this. We can really get at this over time. So I always say when we do these bits of work with practices, the overwhelming impression is, it's a little bit of relief. Like, yeah, we can. This is within our grasp. It's not this big thing. We can really get at this ourselves. So a couple of practical examples, but I think they're really promising.
Great. I'm going to ask Sajid exactly the same question, but just before I do that, I'm just going to say we've got about 10 minutes left. Get your questions in or get your comments in. Andrew, Callum, Hamish, we're getting some great questions in. But by the way, I don't think the NHS is a supermarket. Don't worry about that. But if you can really get your questions in, that would be great. Saj, a couple of really practical examples where we've done this, and we're doing more than just creating more appointments.
So one of the things that we do as part of the General Practice Improvement Programme is a module called Appropriate Appointments. We're actually even just looking at the work that practices do, how much of that is avoidable or unavoidable, right? How much of it is appropriate or inappropriate. And this is where we can, some quick analysis and doing some data capture over a period of time, a week or so, from clinicians, we can understand, should that patient have come to yourself? So i.e. whether that's a GP, all the different ARs and roles that exist, we can do that analysis and already understand, should that patient seen you, or do you think it could have been seen by A, another clinician in the practice, 2, didn't need a face-to-face appointment, could have been managed through a telephone or other, OC consults, or 3, did not need to be seen at all. Yeah, that could be managed by self-care, going to the pharmacist, etc., etc. So when we do that, generally we find, and previously we found a lot more higher percentage. Now that we've got the triage and signposting in place, we find that the numbers are a lot smaller. But still, even with large practices, if you make, like Nick said, that compound interest, a 5 to 10% difference on that number, it has a massive effect on your access and availability of appointments within your practice. The other tool, the other process or module that we use is called frequent attenders. Right? And this is looking at those patients that attend the practice most often. And sometimes by doing some really quick analysis over the previous year, understanding the patients and how often they come in, we're able to understand that we had X number of patients that came in once or twice, or these small number of patients that came in more than 10, 15, 20, sometimes even up to 100 times within the practice. And now I totally appreciate that those that come in more often generally are more complex patients, have huge challenges, and actually there's very little that a GP or a practice can do to manage those patients, and that care is needed for those patients. But as you start working your way down that patient profile, you come to a group of patients that are coming into the practice, generally sometimes up to 40 to 50 to 60 times under the radar, where practice is not actually aware of those because they're seeing multiple, because now we've got all these different clinicians in the practice, seeing multiple different individuals within that practice. And again, going back to that scenario that we talked about before, how effective are we in those consultations? Because if we're not really managing those patients effectively, they're having to come back in again and again and again and see a different clinician, a different person. And by not managing those individuals, we are going to have a huge problem further down the line when they become reliant upon having to see those GPs more and more often. So by analysing that, by putting then better care plans in place for those patients, or running through some real good MDT meetings and reviewing those patients, we can put action plans in place to proactively manage some of those patients that prevent them having coming back into the practice again. These two little models are really easy and simple to do and allow practices to be able to manage huge volume of patients and the impact that they have on the appointment system that exists within practices.
Thanks, Liz. In your PCM, what are you seeing? Are you creating more appointments, or are you actually creating better healthcare? Is what you're doing reducing pressure on the staff, on the team, because that's really important? And is there a whole thing of actually we can't collect this data in the first place to try and make these changes because we haven't got time to? And are you doing anything around that?
Yeah, so part of the role that I have as digital transformation lead is making sense of that data, both at access level, but also at population health management level as well. So yeah, actively doing that work across a PCN, and using our additional roles staff where it's needed, and that pathway being dictated by the data that we're seeing. So, for example, where you've got high prevalence of patients that may have a serious mental illness or a learning disability, putting in extra appointments outside of the appointments of the practice, but with the additional role staff to help get their sort of annual reviews done. So it's moving a bit of an agile workforce into areas where practices need that support. Granted, most of you on the call will be thinking, how do you get capacity, room capacity? Because we've not even mentioned in this whole discussion around the demand for room space. That's even that could be a webinar on itself, let's be honest, around estates and how do we do this. But quite a lot of our work that we do is, I work in quite a deprived PCN with quite a lot of health inequalities. So a lot of our work and our focus is actually outside of general practice, outside of them for consulting walls, and it's working very closely with communities and doing that point of care testing and going out and seeing patients. So I think we have to think about different models of consulting. We've talked about time, we've talked about multiple different people, but we also need to think about different place as well where we do some of that consulting, not just in them four defined walls of general practice. And then, you know, the next sort of build on that is working in communities, working with other partners, is around working closely and more closely with our colleagues and our partners in secondary care. So you've got a streamlined pathway. You know, I think that is crucial as well, especially when you think about our population and our patients having multiple long-term conditions. And at the moment, in general practice, we are very much, as a healthcare provider, that is single condition focused, and that's due to the way that we're paid, and the way we're incentivized to do that. And we have to break down that single condition consultation model in any sort of modern practice.
Thanks. Bilal, I'm going to give you the final word as time is catching up. It's going to be a 30-seconder, but do you really think that this balancing this preemptive care strategies and maintaining the high can really achieve what Darcy is talking about, getting this high quality of care? Do you think we can do it?
I think so, absolutely. It's not just think we can do it. I think we are all collectively of the opinion that we have to do it. We're all wedded to the NHS, either as clinicians who are working in it, or if we're coming up to retirement, we're thinking, well, in 5-10 years, I'm going to be using this service. So this better be fit for purpose when I'm on the other end of the phone. So yeah, we are all invested in making sure that this works. We've got a great opportunity. We've come through COVID, that, you know, but I think Hamish pointed out that there is that desire to not go back to how we were doing things, that we can do things. We've got a new government coming in, and there isn't going to be more money. We understand that there isn't going to be more workforce, so we have to do things more intelligently. We have to use the skills and the data analysis that's out there to help improve the service better.
Thanks for that. As our final word to our sponsor, Demand and Capacity Optimisation tool, Sajid, you've got a minute. Tell us about it quickly.
So firstly, thank you everybody for joining us today. And as we discussed, we know that preempting patient demand is really crucial for efficient practice management. And I guess that's why we developed the Demand and Capacity Optimisation tool, or DCOT for short. I guess this innovative solution, the intention behind it was to help practices really visualize, one, hidden demand patterns, two, to really optimize their resource allocation depending on those patterns, reduce some waiting times, and then improve patient care quality and continuity if appropriate. So our tool really reveals that unseen trends in your practice operations, helps enable data-driven decision-making that can really help maintain and even improve your performance under increasing pressures, all while focusing on high-quality care. So I just want to say, if you're interested in transforming your approach or understanding your patient demand or being able to manage your demand better, please visit our website or contact us or myself for a demo, for a demonstration. Thanks.
Thank you very much. There's a practical step we can all take. Thank you to my panel, Bilal, Nick, Liz, and Saj. Audience, thank you for your questions. You've been wonderful. Big shout out, October the 31st, spooky date. We're going to talk about that spooky thing. Oh, yes, winter pressures. There'll be some absolute top tips. Join us on the 31st of October. Bring your pumpkins. Thank you for joining us. See you then.
Thank you.